I shall start the session by introducing the convener of this program for today, that is Dr. Ashish Saxena sir. Sir has done MD, FRCP, FIAE, FIACM. He is a consultant critical care, diabetes and clinical non-invasive cardiology, diabetes and heart center at Ludhiana. So sir, now I would request you to please start with the session. Over to you, sir.
Arpita, I'd like you to introduce Dr. Aka and all the panelists also, and then we'll take.
Okay. So we have Dr. Raka Shihore with us. So is MD, consultant and founder of Chairman GDF Madhumir Diabetes Center at Raipur. We have Dr. Shashank Joshi sir, MD, DM, FICP, FRCP, FACE, FRCP from London, Glasgow, Edwin. He is the Padma Shri Awardee recipient at the year 2014. So he is the chair of International Diabetes Federation, Southeast Asia, past dean of the Indian College of Physicians, a member of COVID-19 State Task Force, Maharashtra. Ashish sir, would you like to now introduce the other speakers or shall I do it?
This is Dr. Clarence Samuel. He is MD in Community Medicine, a Vice Principal of CMC Ludhiana, and he has been in the COVID Task Force of the state of Punjab. He was recently honored by the Health Minister and the Chief Minister of Punjab for his work, and recently honored by the Health Minister Chhattisgarh for his work in COVID. Next, we have Dr. Nishit Kumar. He's an MD, FARSR consultant in the Department of Pulmonary Medicine at Ranchi. Dr. Nishit has been an instrumental in forming the guidelines for CME India for COVID 2022. So it's an honor to have him on the panel. Next. Dr. Aka, will you introduce the rest of the panelists, please?
Yeah, this is Dr. S.K. Gupta. Nothing to mention Dr. S.K. Gupta for his novice abilities in COVID. He is known as a COVID man. He was really posting interesting things in the CME group, and we have been enlightened from his wisdom of COVID. And it would be a great session, I think, when we all will talk as a panel discussion. Next, please. Dr. N.K. Singh, I don't think nobody here wants any extra introduction for him. He is a pioneer of all kind of whatever we see in the CME group. He's doing everything which from scratch to research, and he is able to join a young brigade with old brigade. So he is amalgamating all kind of knowledge molecules, which I can say. And without wasting time, let's move to the discussion on the platform.
Yeah, as we start the discussion, just a minute of silence for we have lost a very great nightingale of our country.
1 minute.
Just 1 minute silence just for the conclusions, and then we start. Thank you all. It is really a pleasure to have such good panelists, especially Dr. Shashank, Dr. Gupta, Dr. Nishit, Dr. M.K. with us. So I'll start the session. We'll be posting a few questions to our panelists. They are all well planned so that we can have the entire insight of the guidelines as well as what we have to do in the current scenario where a lot of people are thinking that COVID is gone and a lot of doctors have taken down their guard. But we might know from our experts what has been the scenario. So let us start with Dr. Aka. Let us start our session today.
Yeah, because it has been mentioned that Dr. Shashank has to leave early. So my question to Dr. Shashank, straightforward, that our country has faced a third wave and it was not so dangerous. What will be a possible hypothesis behind that? Because it will be a democratic question and we are just grooming our interaction. Let's have such question in the initial start to kick in. Sir, please.
So at the onset, I must congratulate this forum and Raka, your whole group, Ashish. But I have to particularly, put my words out to Dr. N.K. Singh. Dr. N.K. Singh, you are a true uniter. The CME group started, and I compliment you and admire you for your unstinted service for medical education through a group which has now expanded. So I think first my pranam and congratulations to you. I think from this is what digital medicine is all about. This is what is digital medicine to the truest. And I think my salute to you, Dr. N.K. Singh. I really
Thank you, sir.
admire
Thank
you
you.
for doing this outstanding job. And but for you, we would not all be connected here.
Yeah,
So I think that's the truth. And all of y'all, everybody here has done some amazing job. So the third wave, which has come, I can see SK is giving a smile. Nishit has done some outstanding work. Raka, you and Ashish have been there. So the third wave clearly is less severe. No question asked. So let us look at the background. In fact, if there was no Omicron, the likelihood of another wave was remote because we had 80 to 90% seropositivity through natural exposure and or vaccination. See, look at the way at the rate at which India vaccinated. India vaccinated with at least one dose more than 95% today, with two doses 65%. So we had built a vaccine-induced immunity. Exposure in large urban metros due to Delta wave between the months of mid-March to mid-May, those 2 months of last year, we had got a very large exposure. See, for every one infected reported, there were 20 to 30 or 40 unreported. We'll never know the truth of that. You see, but the zero surveys give us an indirect survey. So there was a reasonable amount of delta immunity out there. So we went to the Omicron with some degree of hybrid immunity, vaccine-induced immunity, as well as, and both in adult and pediatric population. And on top of that, the super mutated Omicron is basically a highly contagious but less virulent strain. So I think we were kind of blessed to handle this better. And the other important thing, very, very important to recognize, compared to United Kingdom, we behaved the South African way because of two things. One was that a large part of North India and large part of India, the Delta wave was fully over. There was no tail. So obviously it was like a virgin land when Omicron landed with a lot of hybrid. And the rest of India, like Maharashtra, Mumbai, had a little tail of Delta. Tamil Nadu and some South Indian states had a little tail, and Northeast. They had some degree of Delta there, which remained for a while, but now everything has got swept over again by Omicron. So therefore, in a way, resilient India host immune response is as important as the virus. And therefore, UK, US have not done so well because they had a large proportion of unvaccinated population. And they had Delta at its plateau or a little low, while we got Omicron on a virgin territory with some degree of immunity either to the ancestral strain or to vaccines or to the Delta. So which is why I think the hit has been less severe, but the actual numerical hit is much larger, even compared to the second wave. But we have changed our guidance because asymptomatic people we are not screening, contact tracing we are not doing. So obviously the numbers are not less. We have gone for a symptomatic syndromic approach and we are treating like any other flu-like illness. So there has been a change because it's a predominantly upper airway disease. And because it's a predominant upper airway disease and it has become, see, I used to describe COVID in the first wave as nose COVID, throat COVID, lung COVID. And the Delta was the worst of the lung COVID. Here the lung COVID is virtually out. It's only the nose and throat COVID, which is why we are able to handle it better. So that's my real take on it. I don't want to take too much of time. Everybody will have an opinion, but this is the truth that a nose, only time it descended into the lungs, either it was a Delta or there was an underlying lung disease or underlying severe immunocompromised state, or there was a people behaving like an unvaccinated state, or they had some other major illness. But for that, we are good. So less severe complications, less severe disease, lesser mortality, almost by tune of 80-90%. And we got hit badly. It's not that people, families and families got affected. Whether it was Delhi, it was Mumbai, but we are clearly seeing a decline.
So a small counter to that, we have same ethnic background in Pakistan, Bangladesh, and all, and their vaccination rate was not so high. In spite of that, that wave third has been appreciated as a non-severe wave there also. So it whether being Indian or being Indian background is also an immunity factor.
So genetics of this Raka is not unknown. We would
Yeah.
not, I would not, I'm not so sure of that. But I'm
Okay.
not so sure whether they have sufficient degree of tests.
Yeah.
See,
Okay.
India has done tremendous capacity building. SK will agree with me the number of capacity building we have done here. जहाँ यहाँ पे जो turnaround है टेस्ट का, if you go to United States, वहाँ पे 3 days it takes, 2 days it takes to get a result. You go to Pakistan or Bangladesh, you don't get a result on the same day. We have everything here. We have self-test kits, भर के. We have RT-PCR turnaround time, 12 to 48, 24 hours. We have all facilities. We have upscaled our facilities. We have to congratulate our central and state governments. They have risen up to the place. And our private and public sector both have joined hands together for a common goal. So I think the way we have handled, whether it's diagnostics or therapeutics, I think we have been much more robust in our response. So our two numbers are reasonably correct to a great extent, at least the trend.
Yeah.
While the true numbers there, I don't know.
Yeah, very well said, sir. Because the paucity of time is there, and Dr. S.K. Gupta sir has also joined. Dr. S.K. Gupta, you want to add something on this? Our first question and second question, you have listened?
I've been all through. Thank you.
Yeah.
Thank you, sir, Dr. Shashank, and thank you so much, all of you, Dr. Ashish and Dr. Raka, and my salutes to Dr. N.K. Singh,
Thank you.
who have joined me, who have let me join this forum, and so many other people all across India. My reaction to the fact that we have a slightly lower case, if we see the scenario all over, we see that the maximum number of cases are seen in the UK and USA and Europe. And the second largest group is there in the Southeast Asia. And the third and the least number of cases have been seen in the I would say in the Africa. Maybe that it is that the cases are not being reported. But deaths are something which cannot go unnoticed. I'm saying about death. Maximum number of deaths have occurred in the USA, UK, Europe, and we are in the middle. My take on this subject is that we have been using the killed virus vaccines, which I believe are going to be giving better T cell immunity than the mRNA vaccines, which are robust in their immunity as far as the neutralizing antibodies are concerned. But whether they provided long-lasting immunity, we do not really know. But more is the vaccination, and more is the number of deaths. We nearly, as you said, that probably the innate immunity of the Indians and the Chinese, where the killed virus vaccine was used. They are the two countries where large number of vaccines, these sort of vaccines, vector-based vaccines and the killed virus vaccines. And both these countries, and they nearly form nearly 40% of the population. We really need to turn our cameras to these countries and learn what we are missing. Are we really too much for the mRNA vaccines? This is second. This is my uptake. Second question was the building, capacity building. Wonderful. Our government has done a wonderful job. We nearly had very low capacity to have the RT-PCR. Now the RT-PCR is being done at very, very low cost, say less than $10. In USA, it is going to cost around $20, and that too report comes after 3 days. But we are lacking in one place. That is the genome testing.
Yeah.
We need to build up this capacity. And the genome testing is being done very little in India, and the maximum data is coming from the USA and UK. I think we lost this opportunity. I don't know why. Why did we lose this opportunity? Why does government not allow the private sector to step into this arena and build up the cases? Now the Omicron has been replaced by BA2 version. More than 90% of the cases all across India are BA2 version, which is luckily is a milder version. But people are, of course, initially they were thinking that it is behaving like Delta. But with the course of time, as the things unfolded, we came to know that it is as mild a version as the Omicron itself was. But had it been a better opportunity for the people to get the genome testing, the things could have been far better.
I will extend the question to Dr. Shashank sir because sir has to leave early. Sir, it has been seen that entire management of COVID-19 depends upon the time of diagnosis and how to identify the first day. Although the epidemic and this large victimized population and what the scenario is coming is gone, but what is your take? What is your lesson to the patients who comes with this viral infections? Day one, how to identify day one?
So, Raka, this is a tough one.
Yeah.
Any symptom can be COVID in COVID times. That is my first thing, simple. Second thing, the only thing we know about COVID is predictably unpredictable. Second point. Third thing, what we know is that three classic symptoms which started the ancestral Wuhan strain were fever. That's why we had those thermal scans even today, and it's back in Omicron again. Okay, Delta skipped it. Second is cough, initially non-productive, now it has become a little bit productive. Okay, and the third was breathlessness. These are the classic symptoms. Lack of taste and smell. For a Synergicon with Delta, probably they have gone with Omicron. So those are the five. Persistent fatigue, headache, backache, diarrhea, even a rash. Any symptom with a remote possibility of any of these alert you to do a test and suspect and isolate. That's the first thing. So very rightly you said that though our day one is very difficult to pick up, an alert person can pick it up. So in whom is it very relevant to pick it up on day one? In the vulnerable group, when people above 45, 50, number one. Number two, people who have immunocompromised states, moderate or severe. Or number three, they have underlying comorbidities, whether it is hypertension, diabetes, heart disease, lung disease, liver disease, whatever it is. So these are the classic where you need your index of suspicion very high, and until proven otherwise, look it as a COVID. And then only you will pick up the day one, day two very fast. But in the Omicron wave, for me, the hierarchical preference on fever was high. If there is persistent fever, persistent cough, or breathlessness, my red alert is very high. This triad has still not changed to a great extent. There are mimics, but mimics form maybe 30%. In the original strain, the mimics formed around 10%. So there has been a metamorphosis. There are also some geographic variations. I'm not saying that there are no geographic variations. So you have to pick it. It's hit hard, hit early. And if you are with the self-testing, if you are getting an antigen positive, it's a contagious, the viral load is high, and if the antigen is positive, you are done. And that's a great thing. At 250 rupees, 150 rupees, you have an antigen test available at home, you self-test, you are positive. It's unlikely to be a false positive. Unlikely. So obviously we were more equipped there. Pulse oximeter, which was so relevant in the first and second wave, actually has dwindled down in the third wave. And the thermometer is back again. So I think that's how I would put it. You're absolutely right that every day of the COVID timetable, and original timetable was 14 to 21 days, has got shrunk now to 5 to 7 days. And that what we should look at 5 and 7th day has now become second and third day. So it's actually not really the first day, which is not easy to pick up. It's the third day to fifth day, which is where the third wave has moved us from the second wave. That's how I would put it. But as I said, COVID is like a chameleon. It keeps on changing its clothes. The virus keeps on changing its coats and clothes. And its coats and clothes, and I agree with SK completely, that we definitely needed better genomic and privatization of genomics. In fact, I have one more thing to tell you, science facts. A multiplex PCR can easily pick up all those mutations. And multiplex PCR is available in private. A lot of ID labs and people who work in infectious diseases, and though I'm an endocrinologist, I used to work in infectious diseases before my endocrine days. I did a lot of work in my HIV/AIDS days. I am fully trained in immunology and infectious diseases. We have multiplex PCR. And there are labs in India who can actually, while it is cheaper, and the turnaround time, you can actually identify BA1 or BA2 or BA3 within 12 hours. See, genomic testing is expensive. You need a nanopore. You need to take at least 48 hours for the turnaround time. Genomic labs, by the time they turn around, it takes a couple of days. The way the sample has to be transported is like a Pfizer vaccine, -20 to -70. While here, the multiplex PCR can actually pick it up much faster. So actually, had we used this, we would have been able to upscale it. So that's a miss. Nevertheless, because the strain, as SK said, is less virulent, we have taken the risk. In fact, if you go to say just Middle East or UK or US, every sample is genomically tested. So they exactly know what is responding, what is not responding. Well, we missed that bus a little bit. In fact, we didn't generate, we saw a lot of clinical material, but we didn't generate high quality original work. That's because we were too overwhelmed with work, and I think that's really the challenge. But I think I agree with you. Hit hard, hit early, pick it on day 1, 2, 3, 4, 5, and it's still fever, cough, and breathlessness, which are the red flags. Smell and taste are very much there. Persistent fatigue is very much on the high alert. Nose, throat COVID overtook the lung COVID.
Sir, going with the rationale of your knowledge and science vista, and you are in the top gear in the top chair of Maharashtra Task Force, we have enough sample collected in minus 40 degrees centigrade. They have been keeping also. Whether they are going to post process for genome sequencing in your area, because you've suffered a lot, that Maharashtra and Kerala has suffered a lot. But
So we started genomic testing. So in the month of May, we tied up a MOU with the IGIB with Dr. Anurag Agarwal's group from Faridabad. And from we have 33 districts in our state. Every district, every week, 100 samples go. So if you ask me, Mumbai city, how much percent is Delta, how much is Delta plus, how much is Delta derivative, and how much is Omicron, every week I have a report, which I can post, which I post up sometimes on Twitter. So I exactly know right now that 3 weeks back, we were 88% Omicron. And among the 12%, there were Delta derivatives, and there was 2% of Kappa still there. But as of Saturday, which was yesterday, today is Sunday, okay, we know that more than 92% is Delta derivative is out, it is Omicron. And among that Omicron, we also have some granularity, which SK is saying, is probability is BA2. And we also know that within those 8% which are remaining, they are predominantly Delta derivatives and Kappa is not. So clearly we know that the overwhelming strain now, but if you come to Delhi, for example, and Delhi is also done a lot of genomics, comparatively, I mean, I'm not saying the percentage-wise they are still very low, they are 95% plus Omicron. So at least that data is there, percentage data is there. Numerically, what SK was alluding to, if total number in at least 5% or 2% should be screened for genomics. That was not on the total. But as I said, now the denominator only changed because the screen tool changed because we removed asymptomatics out.
thank you, sir.
Initially, Delhi was like trying to test every sample, and they made a promise that they'll be testing. Later on, they made a promise that they'll be testing for 5% of the samples. But now it is back to again only 1% of the samples are being sent. And Bihar, of course, has done very poorly in the genomic testing. Hardly 1 or 2 samples have been processed in the Bihar laboratories. I think we need to ramp up that capacity in the Bihar. There are a lot of patients over there, but probably the labs over there are not able to perform. I don't know what is the reason. Dr. NK might be able to post some ideas.
Any data from Kerala?
Kerala also has the same tie-up like Maharashtra. Every state, every 18 districts of Kerala, they sent samples to IGIB, and they had a lot of Delta derivatives. So Delta stayed there. Now again, it has been replaced by Omicron.
Dr. Nisith,
Ashish.
yeah, Dr.
Yeah,
Nisith, he can.
I'll like to ask
yeah.
you, in this era where there is so much going around in the social media, lots of prescriptions are floating across patients and relatives, doctors. So there are certain lot of patients who are asymptomatic carriers. And another thing is what we have, like, what should be the prescription for these patients who are post-COVID Omicron or post-COVID whatever we are seeing, because we don't have the genomic sequencing. And can you tell us a little bit about the post-COVID syndrome, like how we can identify these patients, how can we go about treating these patients?
Asymptomatic patients need no treatment, but post-COVID syndrome clearly seen and visible. Currently, from Omicron wave, because Bombay, unfortunately, the shores of Mumbai, which you can see behind my house, which is there on my background, hits it first. And unfortunately, we get fatigue, which persists. We get new onset diabetes, which persists. We have seen a little small increase of myocardial infarctions and strokes, but we are not so sure. We have seen high D dimers. But we are not so sure whether it's a winter effect with underlying cardiometabolic disease or whether it is true Omicron related effect. And maybe the BA1 had it more than the BA2, probably. But now it is gradually coming out. So therefore, I have used in that high risk population a, a antiplatelet agent like low-dose aspirin. And often because of the type of patients I see, I have used the statin. So I have co-prescribed that apart from symptomatic management. But otherwise, by and large, things have been reasonably okay. Post-COVID syndrome is going to be there. In Omicron, I don't have currently adequate depth on that because the disease came to Mumbai only around second week of December. We are talking in the first week of February. So I think we need to wait. But clearly, I think memory loss, some neuropsychiatric challenges, persistent fatigue is going to be seen apart from diabetes and apart from a little bit of probably bleeding or clotting phenomenon. But as I said, these are all anecdotal from my side. But there is a likelihood of probability and possibility going to be there. Dr. Pandit, who is my critical care counterpart, he and me both believe that there is a little probable statistical increase in heart attacks and strokes. But as I said, again, this is completely anecdotal because it's that this is a time when in winter time, usually the blood pressure is at a higher nadir and there is a little bit of circadian biology involved and the clotting phenomenon is a little more, thrombotic phenomenon is a little more. So probably it could be just a winter effect. So we don't know.
Sir, do you feel in the coming few months some new strain is going to come, or we can say, like, with a little bit of surety that this pandemic becomes an endemic and then goes off? Because it is not behaving like swine flu, it is something different. Just because you are an expert, so I'm asking you.
So the right person to answer this question is, of course, SK. And SK, I'm sure, will give his pearls of wisdom on this. And he's written some very beautiful articles and his narrative is fantastic. So the narrative in the second pandemic was herd immunity. Herd immunity came in and came out. Okay, it was like a narrative being built, science narrative. The narrative in this is endemic. To end the pandemic, they are using this word endemic. But according to me, neither of this is, as I said, the only thing we know about COVID is predictably unpredictable. Evolution-wise, the strain of Omicron was less severe, more contagious. Is it a freak strain? And will we still get a Delta versus strain? Okay, will we get it? The chances are low. But the probable likelihood after 6 months to 9 months, we might get one more strain. We might have to live with COVID. We will have to make it a manageable disease like dengue, malaria. We will have to treat it. That is what is endemicity of all about. So we might need and we might have one more strain. I feel, this is my personal take, and as I said, I could be completely wrong. Okay, I feel that in another month and a half, we will have some respite and relief for a good 6 months with some degree of immunity. And then if there is some, again, as I said, if we don't vaccinate the world, there are 7 billion people in the world. If we don't vaccinate world and we get another mutation, which is much more sinister, we were lucky this time. We were lucky because probably these mutations, did not get the virulence or the teeth the virus needed. So so there was a fear about that Botswana French strain which came in, but it's really not made the cut. See, there are a lot of viral variants of concern, interest in the circulation, or variants of just suspicion. So they are probably there, but I personally feel we are through. We probably may get one more strain which is likely to be less virulent, maybe more contagious, but we have to live with COVID. I think disruption-free COVID is a reality. Okay, it's unlikely to disrupt our lives. Yeah. The way it did in the first wave and the second wave, the third wave did disrupt our lives, but not to the level of extent and the mortality. So what is the new mantra in COVID? Zero COVID deaths. That's the first mantra. We should not live a single life. Number 2, less severe COVID. That's the second mantra. Number 3, learn to handle COVID like any other disease and focus on non-COVID work. Those are my 3 final points I would like to talk. Yeah. Because I think that's where we are. And as I said, if you want more teething and teetering of knowledge, you have SK with you. He is a brilliant encyclopedia on that.
What is my take on this? If you see the evolution of COVID,
Dr. Clarence is there on the waiting. Can you just let him in, please?
Yeah. SK sir, please go on.
if you see the evolution of the virus, you find that the second virus or this new variant can prevail only if there is that variant is much more transmissible and it has the capacity to displace. There's a lot of multiplication going in the throat, in the nose, and there are so many new variants that come up. You just heard about the neocov and so many new variants are going to be the variants of interest. Why these variants do not prevail over the existing variants? These variants can prevail over the existing variants only if these variants are much more transmissible. And as Professor Shashank said, that we are lucky that these variants are definitely much more milder. And as I said in the beginning of this pandemic, the Omicron has come here to give you the immunity. And the evolution pattern, if you see these viruses, that they give you the immunity over the past variants, the previous variants. The Omicron gives you the immunity against the Delta variant, and that's why the Delta has been displaced from the virus sphere. And the Delta gave you the immunity against the Alpha, and the Alpha gave you the immunity against the original Wuhan virus. So these variants have been evolving so as to displace, and they can displace only if they can override that immunity, and they can have a faster transmission. So as Sir said that we might have another virus, but of course we are protected for 6 months, and that has been the pattern over the last 1.5 years or 2 years that we have been seeing the variants taking over the virus sphere only after 6 months. Maybe because the booster dose immunity, or maybe because the vaccine immunity, or maybe the asymptomatic infection or the infection immunity. At least it persists for about 6 months. That could be one reason that we are having the variants. We actually do not know, but we might be having another variant coming up very about 6 months from now, or maybe 4-5 months from now. But whether this variant will be much more virulent, we have to be hopeful, and I hope that we might have a variant which might be much more transmissible, but definitely much more milder than this variant. And people are going to accept it, and this is going to give us an acceptable mortality, and that's where we are going to live with it. Otherwise, in case the variant is very virulent, the things might be in havoc again, but the probability of that is very, very low.
Dr. Nishit, I'd like to ask you, Arpita, are you there, please? This Dr. Clarence is trying to get in. Can you just look into it? Say the host has to get in.
Dr. Asit, can you call him?
Yeah, I'd like to ask you, looking through all the thought processes going around in the society, a lot of fellow physicians, they also proclaim and say that COVID is dead. Now, what are the challenges that you see in the management of COVID in 2023?
Well, sir, the question we need to ask ourselves is, are we ready to live with COVID-19? So, in absence of definite treatment, the most effective measure is, of course, to prevent infection by vaccination and by booster dosing and all, and practicing adequate hand hygiene, wearing masks, following social distance measure, which we used in first and second wave. So, but it's very important in a bit to make faster clinical decision. It is very important to detect the type of variant in the very beginning. As you all know that many variants, including Delta, is still present in community. However, the number is quite less, the percentage is quite less. But after genetic sequencing, it will be very clear, and it will help the clinician to decide whether there is any need of any specific therapy for a specific case. For example, we all know that for Delta variant, we have got monoclonal antibody, which is effective, but in Omicron cases, it's of no use. So at present, there is a lot of confusion going on. So Omicron is already causing breakthrough infection, and for vaccine manufacturer, they have got a daunting task at hand to decide whether new vaccines are needed, not just for Omicron, also for whatever comes next, as Dr. S.K. Gupta sir said. So the Omicron wave is already cresting, we all know that, and globally the countries are now opening up. They are starting to reopen, but at the moment, it's hard to tell where things are. Opening and jumping between lockdown is happening all over the places in our state and your state also. So with the rise and fall of cases, but everything depends upon what comes next after Omicron. So we might be having 3 or 4 months of breathing period, as Dr. S. K. Gupta sir and Sasank sir just said. So that's the way forward.
I'll ask a question to Dr. S.K. Gupta. Sir, clinically, when we are having a patient who is breathlessness, and there are some changes in the saturation. Now, we have talked about Omicron, we have talked about the Delta. I am talking about a normal physician, at least OPD, a patient lands up, and he complains of fever and cough. And the thing which I have noticed is they might be having fever for 3 4 days, and they just say, "This happens, sir. This happens," and it is not COVID. It is difficult for them to tell you, please get a COVID test done. So, like for a clinician, how do we recognize on day one certain signs if the patient gets admitted, or the signs where we can say that the patient can be going into acute respiratory illness, and how can we prevent that?
Thank you, Ashish. I think that this question has become slightly less relevant in the world of Omicron or the BA2 variant. This was much more relevant in the Delta wave. Now the infections becoming much more milder. This question remains relevant only in the cases of patients with comorbidities, very elderly patients, or patients who have immunocompromised status because of certain reasons. My take on the subject is that we need to keep a very high index of suspicion for the patients who have comorbidities, who are obese, who have underlying CKD, who have underlying cardiac failure, or whatever reasons, the diabetes, uncontrolled diabetes, or morbidly obese people. If these patients, and one thing which I have seen in the past, the elderly people do not presenting with the fever. They had only subtle symptoms, that loss of appetite. They stopped walking. They became lethargic. Probably fever did not manifest in them. So we need to always keep a very high index of suspicion. But and monitoring the saturation by way of using the pulse oximeter. But there were a lot of questions posed to me with how can we have a pulse oximeter in the periphery. Then came the idea of these breath tests, the breath holding test, and the counting the Roth test, counting 1 to 30 in the native language. But these tests, they have been pretty like they had been very crude tests. Sometimes we could miss many of these patients because the breath holding capacity of any person may vary with the exercise capacity, and even the athletes may not be able to hold the breath. And even a young woman who have been using the Fupni in the chula might be able to hold the breath test. So probably more important than all these things would be the persistence of fever. If the patient is having persistent fever, if the patient is having persistent cough, if the patient is having tachypnea, his exercise capacity has gone down, he is not able to walk down to the bathroom, he is not able to wear the clothes. These are the people who should be picked up, and they should be tested for saturation, and they should be initiated with the initial treatment, either by way of remdesivir or maybe because of by way of monoclonal antibodies, though they might have become less useful or non-useful in these days. But antiviral therapy may be initiated, and that they should be kept in the high index of situation, and they should be admitted at least. And in case the saturation drops down with the 6 minute steps, maybe early, maybe, and the saturation also may vary from person to person. For an elderly patient who is having COPD or underlying lung disease, the saturation of less than 92 might be acceptable. But for a young patient, a saturation of less than 94 or 95 might be something very sinister. And we need to keep these patients under observation. That's how I'm going to take it. And to see whether this is day one or day two. Even my son, I tell you, my son who had COVID, initial 1 or 2 days, he said, "Yeah, Papa, I'm not well." I said him, get a COVID test done. He said, "No, I'm fine." And the third day he got a COVID test done. We might have a good index of suspicion, but we may not get tested. And luckily, this time we do not have very severe COVID, so we are going ahead with comfortably well. Otherwise, things might have been different from earlier.
Yeah, very well said, sir. My question to NK, sir.
Yeah.
See, this is the milder form, and that there we have gone through this very well, and Dr. SK sir, and we all have suffered same thing in our families. Our kids have high degree of neglect because of our own decisions, because we were just not going to get for ready to get them for the test also. So there was the same thing. But how do you take, because it's in a metabolic mayhem, there is a lot many patients coming with diabetes. So what are the red flag signs, and how you counter those patients as a DD, differential diagnosis for HRCT and CT or X-ray chest, Dr. NK sir? How
Uh,
you classify?
yeah, thank you, Dr. Raka. Let me, Dr. Assis also was in favor that some slides should be shared in between. So let me give three. I will just share here three slides only. So
Okay.
yeah, so I think for viewers will be more. It will be better for the viewers also. So see here that this CME India COVID management protocol we are today discussing different guidelines also we will discuss. So luckily this when we made this guideline and Dr. Nisit is here, I was really not sure, but anyway worldwide it was around 4 lakhs downloads so far. So I think that was pretty high index for a guideline from uh,
Great, great.
for this website. So we have discussed, I think still today I don't find a very comprehensive guideline dealing everything of the COVID, almost everything. And we have also the vaccination protocol, and we have also the post-COVID uh, management protocol. So I think let you, yes, you are asking about the red flag signs. Today I just this was shared in our group by Dr. Padmanabha. I think really this is, we can be happy here that January 29 to you see the February 5, including this Kerala, Karnataka, Delhi, West Bengal, Uttar Pradesh, Maharashtra, Haryana, this has become green. So Dr. Ashish was when he talked to me whether he was very skeptical what will happen to COVID science. This science will remain, and maybe some people will lose interest as the green index increases. So anyway, this is a, I think a good news. So I thought we said. So first in COVID management, this is most important to know the day one, and this is was very difficult at least in this Omicron wave, I will say. Even in the Delta wave or second wave, I think there were some symptoms or some things were very pertinent by which it was very easy to say that, oh, this is the first day first. And most of time, the history taking is very poor. And sometimes this time many people started only with chills, backache, next day the fever comes. So I think that should be taken as a day one for this symptom. So you are well aware, not going detail, but mild illness, moderate illness, and severe illness. This category, how to differentiate is well known to you all. So this is very important. So we did, and we displayed in our guidelines these red flag signs, if developed, are likely to deteriorate. And so these 4 or 5 things are very important. One is the high grade fever. See the high grade fever and severe cough. Luckily in the Omicron wave this was not found. The shortness of breath, as Dr. S.K. Gupta beautifully is already told about while walking, talking, sitting, tightness in the chest, feeling of disorientation. Many people we get this time also getting this, and the slurred speech, seizures, unable to wake up or stay awake, or if you see the respiratory rate, that is if more than 24, and then definitely oxygen saturation, but still there are lots of caveats as Dr. S.K. Gupta already explained. So the point is that a low threshold should be kept for patients with high risk factors, and this is the very important catchy point. You see, you just assess your patient ki whether it comes in high risk factor group or what are the comorbidities. So if you see this one, I think it will be able to catch the red flag signs, because today we have got the modalities to treat many of such cases, and we can save our patients. So this is important. Although this slide I will not say you much about that, because this was basically relevant in the Delta wave and the indications of steroids in non-severe COVID. That was after 5 to 7 days from the onset of symptoms, and then the many things were we were doing like temperature, the oxygen saturation, 6-minute walk test, then also some clinical scoring system came, and then repeat inflammatory markers. But this time I am really pretty sure that most of us, even we didn't went or we didn't advise to our patients regularly for the 6-minute walk test. It has not been done in most of the family, as I am aware. So I will not go in detail here, but be vigilant. Lastly, I will say here that be vigilant. If fever is persisting and more than 103 degree Fahrenheit without antibiotics, if there is persistent cough starting after day 3, sudden onset of shortness of breath, rapid rise in CRP. So this again in high risk cases, this test gives you very much insight to pick up many of the moderate or patients who need hospitalization. And if then you do CT or X-ray and you get the more than 50% of lung involvement, altered sensorium, think again. So clinicians should be aware of the potential for some patients to rapidly deteriorate 1 week after illness onset. So I think I will stop sharing and for next time. But I think these are the very basic things. I think Nisit, could you elaborate anything more on this point, these points?
Yeah, I think I will talk about a little bit about management of COVID-19 in present scenario, because there are lots of confusing whether to use antiviral or not. So, as you rightly said, that categorizing the disease into mild, moderate, severe, and maybe critical illness is very important right at the onset when you see the patient. Now, we have seen that Omicron illness is usually mild. We just need to treat it symptomatically with antibiotics, antihistamines, and antitussive if the patient is complaining of cough. So there is, I would like to say categorically this thing that there is no role of azithromycin, doxycycline, ivermectin, HCQS, etc. in present scenario. So option for treatment of ambulatory patients who are at high risk includes Paxlovid, which is not available in India. Second option is 3-day treatment with remdesivir. Again, in such cases where the patient is at high risk, you can admit the patient in hospital and you can then administer remdesivir for 3 days. Another option is molnupiravir, about which I will talk, and then monoclonal antibody like the antibody cocktail, which is relevant for Delta variant but not for Omicron. And sotramivab is not available in India, so there's no point in talking about it. So basically, for ambulatory patients with mild to moderate COVID-19 illness who are at high risk of progressing to severe disease, those subset of patients who are elderly, who are more than 60 years of age, who are having multiple comorbidity, remdesivir can be used within 7 days of symptom onset. So knowing day 1 is again very important, although it's a bit difficult in present era. And the dosing of remdesivir is 200 mg stat on day 1 and followed by 100 mg on day 2 and day 3. That's it. So it prevents or cuts down the hospitalization rate by around 86% as per literature. So for OPD patients who are more than 18 years of age with mild to moderate COVID-19 and are high risk for progression to severe disease, who have no other treatment option. Suppose you cannot give him remdesivir if it's not available or it's not possible to administer it, then molnupiravir can be initiated within 5 days of symptom onset. Dose, as you all know, is 800 mg twice daily for 5 days. And it's very important to know about the contraindication. It is contraindicated in less than 18 years of patient, as it may affect bone and cartilage growth. And also it is not recommended for use during pregnancy. There are reproductive concerns as well. So it should be used with caution in patients who are in childbearing age group. And patients should be advised to follow contraceptive measure for next 3 months, at least next 3 months. Now, as far as those patients who are hospitalized are concerned, for IPD patients, they are generally having severe COVID-19 related illness. They are having low saturation. So this group is basically defined as patients who are having high respiratory rate, more than 24 per minute, with low saturation, that is less than 94% on room air. So there, in this subgroup, oral corticosteroid or corticosteroid like IV corticosteroid like dexamethasone 6 mg by IV or oral route is indicated for 10 days, and also low molecular weight heparin in prophylactic dose if there is a risk factor for thrombotic event or disease. So IV corticosteroid for severely ill patients who are hypoxic remains the mainstay of therapy. So no role of steroid in non-hypoxic patient. in this present scenario. And also IDSS suggests remdesivir in severe illness also, but it is debatable. Now, among hospitalized adults with progressive disease who have elevated markers, as Dr. N.K. Singh sir rightly mentioned, you can get a CRP done. It is quite a cheap test. So, tocilizumab in addition to steroid can be given where the inflammatory markers are progressively increasing, and if they are at high risk of progressing to critical illness. And again, baricitinib, where tocilizumab is or IL-6 inhibitor is contraindicated, or if it's not available, then you can give them baricitinib, which is again the dose is 4 mg per day, and it can be given for up to 14 days along with remdesivir or steroid also. And baricitinib appears to demonstrate the most benefit in those subgroup of patients who are having severe COVID-19 illness, along with if they are on high flow oxygen. Again, I'd like to say that there is no role of convalescent plasma. Its role has already gone down after second wave. So that's about the management of COVID-19 for OPD and IPD patients.
Dr. Nitish, just I will ask that many people ask that in vaccinated persons, are you going to use this the antiviral drug Molu or not?
Well, sir, that's a difficult question to answer to start with, because all the studies that have been done for molnupiravir, like Move Out trial, they had included those subgroup of patients who were unvaccinated and who were at high risk of progressing to severe illness. So we really don't know whether if you use it in vaccinated population who are partially vaccinated or who are vaccinated, if it's going to help. Subgroup analysis have shown that it won't be of much help in vaccinated population, but it also depends upon the antibody titer, but it's very difficult to measure in present scenario. So, of course, if someone is in high risk group, elderly patient who are having multiple comorbidity, or if someone is on immunosuppressive therapy, and if they have taken vaccine a long back, maybe 6 months or 8 months back, so they have waning immunity level. So in that subgroup of patient, you can use molnupiravir with caution.
So, Doctor, thanks for the discussion.
Can I make a point? Nitish, can I make a point?
Yeah.
Yes.
See, the trial was done on the unvaccinated patient. When we have a patient who is immunocompromised, who is likely to deteriorate further, and we have a reasonably economical drug, the molnupiravir, and if we give the drug, does it cause any harm? I really don't think that it causes any harm. We are always tempted to use the drug. I have used it in some patients who are vaccinated also. So there is no contraindication to use the drug in the vaccinated people.
Yeah, that is true.
May it be effective, may not be effective, but absolutely there is no relative or even absolute contraindication to use the drug.
Sir,
even in the vaccinated people.
clinical scenario itself says then when a vaccinated patient succumbs, then itself it's a story that you need to treat it with a drug. So vaccine is not working. That's why we need to go ahead with that. Dr. S.K. Sir, you are very correct that we need to try. And Dr. Clarence is in. Welcome, sir. Welcome. You joined a bit time late. We had a discussion, and you are a person from task force. So I want to ask, what is the current vaccination policy, and what we are talking most of the times about booster dose? Where do we stand, especially when we are moving with so many things going in social media? Doctors are scared. Whom should we go for booster? What is the booster criteria? Whether all of us have been that vaccinated? We all have been vaccinated here or not? I am still not in the booster category. So, what is your take?
Good evening, everyone. I was having some technical issues. Apologies for that. The booster dose, we call it the protective dose in our country, is something which a lot of debate is on, as you're saying, and a lot of doubts. But it's important that we understand that immunity from vaccines will wane over time, and even natural immunity will wane over time. And booster doses for healthcare workers, frontline workers, as indicated, is actually the current guidelines, and I think it is the correct guidelines. We have an issue right now with mix and match, but there are studies going on with mix and match vaccines. AstraZeneca. Majority of India has got the Covishield vaccine, and AstraZeneca has shown that the booster dose or the third dose with another vaccine produces higher antibodies. But in our country, we continue with the policy that if you've received one vaccine, you will continue with the same vaccine, partly because of variety of reasons. One is who would take responsibility if there is a reaction, which, how would you attribute the reaction to the first vaccine or the second vaccine? And we have all these other legalities that are there. Keeping that in mind, the current policy is that you would get the same vaccine that you got in the first two doses. We look at it, there are a lot of myths, but as was pointed out earlier also, in September, October, we had around 85% of the unvaccinated with antibodies, not the vaccinated. So if you look at the antibodies from natural infection itself, we have around 85-90%. So we should looking at vaccine equity around the world and the logistics with recommending the third dose for everyone, I don't think that would be the right policy. Current government policy that only those above 60 and comorbidities, I would go with that currently. Once we have everyone in our country vaccinated, then we should think about, the third dose for everyone else.
Dr. Samuel, I had a very important question, and Dr. Gupta is also actually expert on that. What do you recommend for our, the schools have been opening now. So do you recommend after 8 year or 5 years above this our pediatric population that should be also vaccinated? What is your take on that?
I have a declaration first. I am involved in vaccine trials also, and I have a pediatric trial going on. But as you say, we have seen for so many years that vaccine saved lives. Without a doubt, whether it is typhoid vaccine, cholera vaccine, polio vaccine, we have seen that vaccine saved lives. And over the last, 2020, I was one of those who were very, very skeptical as how efficacious or how effective these new vaccines would be. And studies that have come out and have shown, I actually am overwhelmingly in favor of COVID vaccines for all age groups.
And can I give my...
Yeah, Dr. Gupta, you please give your opinion.
Please, Dr. Samuel, to continue. I'll give my take on it later.
Yeah. Dr. Samuel, anything more?
So in vaccines, they generally start with the adult, any trial, they start with the adult population, then it is 15 to 18, then 12 to 15, 7 to 12, 2 to 6. So that is how trials normally are done. And the government currently is also in the same policy that first it is 15 to, though they have given approval to all these vaccines, both the Zydus and Covaxin have got approval. They would start first with the 15 age group. I think that around 53-54% have been vaccinated. And then they would go to the lower age groups and the lower age groups. Dr. Gupta, over to you.
Thank you, sir. I think what you have said is absolutely correct. Right now, it might appear that we may not need to vaccinate the kids. And once the entire adult population has been vaccinated, these kids are going to grow and get to become adults in due course of time. And in case most of the adults will become immune to the virus in case the new variant does not come. And ultimately, if the children are non-vaccinated, we might have the new population coming into the world. The newborns will become susceptible to the virus, and the virus is here to stay. So ultimately, all the adult population having been vaccinated, we have a cohort of population which is unvaccinated. So we need to vaccinate these new kids so that they become immune to the virus. Secondly, we might rely upon the natural immunity by way of infection or asymptomatic infection or whatever it is, but we cannot rely upon it. We have to vaccinate these children. It is another issue that we do not have the number of doses which are required. Of course, there was some issue with the availability of the co-vaccine, because we cannot give these newer vaccines to the kids, and their trials have not been done. This is my take on the vaccination of the children. I think that whatever the way government is doing, and most of the countries in the world, they have started vaccinating the children. It may not be appear important as of now, but in the times to come, it is going to become much more relevant. Regarding the booster doses, my take on the booster doses is that most of the countries world over, they have been vaccinating the population with the same vaccine. They might have allowed the vaccination with a different mix and match vaccine, but practically most of the countries, may it be USA, may it be Europe, may it be another country, they have, by virtue of availability or by virtue of anything, though there was a trial which showed that the vaccination with a different vaccine is much more beneficial, but practically speaking, most of the countries have vaccinated with the same vaccine, and most of the time the vaccine had been the mRNA vaccine. It is quite a different issue that the people who got vaccinated with the Pfizer now can go for the mRNA, another Moderna vaccine, but it's practically the same. And here in India also, we did not have so many doses of the co-vaccine, and the Novavax trials have not been done. So for me also, if I had been sitting in the place of decision-making body, I would not allow my children to be vaccinated, my population to be vaccinated with the vaccine which have not been tried on the large scale. Over to you, Dr. Samuel, please.
But sir, I think today I got a patient, and I would like to take opinion from Dr. Gupta and Dr. Samuel. The 8-year-old child came to me today with a random sugar of 386. He was on the basal bolus. The mother is asking me, sir, this is a high risk situation here. So why not government is giving vaccine to my child? So how to tackle this case? A type 1 patient, definitely this is uncontrolled, so in high risk category. So why we are not going to vaccinate such? Because already in Jharkhand from the Monday, the schools are reopening. So what to do?
Yes, this is a situation that,
in other
we
words,
have-
we wants to ask that in a broader category, all immunocompromised or such patients who are in category of getting infections and later on, whether there would be any policy you people are thinking about, because you people are sitting with policymakers.
I'm not really with policymakers, but yes.
Policy influencers.
Yeah.
Yeah.
So when you look at a situation like this, you have a program where you make one directive or guideline to be followed for a large population. And right now, as Dr. Gupta was saying, the country is also looking for proving safety in the older adolescent population. Before, because if you start it off, you would have a lot of myths, you'd have a lot of fears, you'd have a lot of vaccine hesitancy, which you don't want to bring about so early. If you remember last year, January 16th, the vaccines were launched for the healthcare and the frontline workers. And there was only 35% uptake for 3 months among healthcare workers. That sort of vaccine hesitancy is also creeping down to the adolescent population with misinformation. So it is important that there is guidelines and there is, everyone is satisfied with the safety. And then you go down to the younger population. To all vaccine, Covaxin and Zydus and Covovax, which Novavax in India is known as Covovax and Biological E, all of them are 2 to 18 population. So the approval would come stage-wise, and then yes, the government would also, the approval would come from 2 to 18, but the government would go stage-wise.
I think Dr. Gupta
wants to leave. I want to ask last question to Dr. S.K. Gupta. One panel, one question was raised in the forum also. What do you say about a vaccine escape phenomena?
Yeah, Dr.
I really did not get it. What is a vaccine escape?
I think in the Omicron wave, vaccine escape phenomena has been found. So how do you take that?
See, we have to learn to live with it, and luckily we are comfortable with the Omicron vaccine. Omicron in itself is acting as a vaccine. We have seen people who were given 2 doses of the vaccine who took the booster dose, but despite all that, they developed a breakthrough infection. And breakthrough infections were much more common in the younger population who were much more exposed to the virus by virtue of their job, by virtue of their excessive mobility. And this phenomenon is going to go. And I think the Omicron subclinical infection or the asymptomatic infection or the symptomatic infection is going to affect a large number of population, and it is going to give a good immunity. It's not only going to give a systemic immunity, it's going to give a local transmission related immunity also. And it is going to be it is going to basically end the pandemic. That's my hope is. That's how the pandemic is going to become an endemic, or maybe it is going to become sporadic in times to come.
I think
Dr.
Dr.
Gupta,
Saxena, let us have final words from all the panelists.
Dr. Samuel wants to say something. Sir,
Yeah.
kindly.
yeah, Dr. Gupta, just a brief thing on Omicron. As was said earlier, we had the lung COVID, and Omicron is more the throat COVID. And the antibody levels with Omicron, with the throat infection, is much lower. And it is more like a local immunity rather than a systemic. So your B cells and T cells are not going to be activated with Omicron. And we have seen, at least we have noticed, anecdotal again, that those who have got infected with Omicron, within the first 1 month, they have their second episode of URIs. I mean, again, we didn't test them because it will continue to be positive from there. And there is a paper which has come out recently showing that 20% of those who have developed BA1 infection will develop BA2 30 days after the first infection. So there is the vaccine escape that is being talked about. So there is no immunity with a throat Omicron, nasopharyngeal Omicron, than with a systemic Omicron. So for us to say that Omicron is a vaccine is a very dangerous statement. It gives a false sense of security. The vaccine is much better. Post-COVID is not there with the vaccine. Complications of Omicron or of COVID is not there. There's a higher incidence of valvular conditions in adolescent populations in UK and New York, which have been reported from Omicron infection. So for us, and from infection. So for us to say infection is a vaccine is dangerous, let us desist from that. Let us continue to say that, vaccines save lives, and let us continue.
The vaccine.
Yeah. I think, I will ask one question from Dr. Naseeth. In my family, I just got a blood test done for the antibody. It is 5 times more than the normal. So in such scenario, taken 2 already vaccinated 6 months back. So how do you see this? There's already vaccine antibody is there. So what do you recommend for taking this booster dose or not? This question is being asked over and over time. So please explain in detail.
Yes, also to add on to that question, like post-COVID vaccination, when can the person take a booster dose? And now recently the guidelines is after the second dose, you have to take it after 6 months. So what is your say on that? And also, Dr. SK and Dr. Clarence.
Yeah, Dr. Naseeth.
Well, sir, it's an established fact that breakthrough infection is happening all over the places. Even I have taken second dose, then also I developed COVID during second wave, as well as I also developed COVID during this Omicron wave. But the point is that it's an established fact that vaccination prevents severe diseases. So if vaccine is preventing severe pneumonia, or if it is preventing hospitalization, then I'm all good for vaccination. There's no point on relying on natural immunity and all that thing. Number one. Number two is about booster dosing. So I think the government has clearly laid out all the guidelines when to take the booster and when not to take it. So if someone has developed Omicron recently or COVID-19 infection recently, then he should get a vaccine after 6 months, as the government has laid.
90 days, I think. Yeah.
3 months.
Yeah, 3 months.
3 months. Yeah. Sorry, 3 months. After 3 months. So that's it. Regarding antibody testing, again, it's depend upon whether you are calculating the whole antibody or you are specifically ordered for spike protein and all. So I think we should not rely on that. Ideally, we should go forward with the vaccine, booster vaccine, at 3 months.
Dr. Gupta, any message from this?
I think vaccines are the life-saving thing, and we have. If you see the first pandemic of the century, which occurred in 1918 and 1919, where the world population has increased tremendously, but we have been able to cut down the immunity, but more than 100 times, and it is courtesy vaccination. And now my take on the subject is that. The science needs to focus on the antiviral drugs. We were able to develop vaccine in less than a year or so. In fact, we developed the vaccines within 3 months. Commendable feat. Nowhere else in the world, or nowhere else, no other disease. The rest of the time, 9 months time was taken for the trials. If we can develop these scenarios, we can have the computer-generated models, we can test the vaccines on the pseudoviruses, and even this trial time can reduce. And now the world needs to focus on development of antivirals. And only by way of these antiviral therapies, we can win over the next. And like if we can have the templates, as we have the templates for the vaccines, we can have the templates for the antiviral drugs also, that we just fit in that part of the genome or that part of the virus into the pseudovirus and start generating the antiviral drugs. That might be our immunity or the protection for the times to come against the new viruses. Otherwise, we have to just rely upon the vaccine. And I feel that everybody should take the vaccines. There is absolutely no saying or no going about it. And if somebody has not had any serious side effects with the vaccine, there is no harm in going for the boosters also. But I am absolutely against the policy of the Israel, that virus is not like Palestinians where you keep on throwing bombs after the bombs and you feel that the virus is good. Virus is very smart. So we have to stop somewhere, because repeat vaccination, the booster dose, again and again booster dose vaccination will not go to be sustainable. That's what my take is. Thank you very much. And I hope there are some people waiting for me.
Yeah, sure. Thank you very much, Dr. Gupta, for giving time. Dr. Raka, I think how to conclude, so you please proceed.
If there are any questions, Arpita, we can have that with the panelists and then we can conclude.
One questions. Can I just ask one question? How many waves did India have? 3 waves, or is it 4 waves?
Delhi had 5 waves.
So if you look at the viruses that we've had, Punjab has had 4 waves. Okay. So we had September 2020, then February, March, we had the Alpha variant, and April, May was the Delta variant, and now we have the Omicron variant.
And now we have the BA2 variant also, but I consider it as a separate variant.
Yeah.
BA2 is a separate, yes, it is.
So Dr. Ashish, with your permission, can I show just 3 or 4 more slides and then we can conclude?
Sir, one more question.
Yeah.
Whether you can differentiate this virus, because post Omicron, most of the patients have suffered from arthromatous that disease and other CV risk complications. Whether this Omicron dose appears to be a throat virus, why it has happened?
I think that Sasank already elaborated about this question, and I think I agree with him that it is very difficult to say at present whether it is due to Omicron or not. But let us see, Dr. Nishit, what do you think?
I'm also not sure. I'm not 100% sure. We are already seeing a bit rise in CV-related cases, but I'm not sure whether it's because of Omicron or it's a natural phenomenon.
Yeah.
It's because of 2 years lockdown or 2 years slag. I think it's more of that.
One thing is clear with COVID is that it affects the endothelium. Yeah. It is a vascular disease. And so, yes, this is, it's not just with Omicron, but we're seeing a higher number with Omicron compared to the earlier ones. In the third wave, or the Delta wave, we did see a lot of post-COVID impaired sugars for 3 to 6 months. And so I think everything comes together, and that is why
the delayed effect of first or second wave, you can say like that.
It's all continuing. It's all part of the same spectrum.
Yeah, yeah.
So, Dr. Naka, can I conclude now?
Yeah, you should conclude, sir. You are the best person to conclude. You
No, no,
sum up the whole
actually, I
discussion.
think well, so just give me 1 minute, so I will share my slides. I think this guideline, I think beautifully made by, I think all of Dr. Sasank is here. So I will not go now here for the children part, which alert was there. This is all in our guideline. So this is for children part, but I straightforward. I will show the few slides. So how to detect Omicron variant? This we didn't discuss. Initially, it was told that you do a PCR test, then there will be S gene dropout. Now everybody is aware that this S gene drop technique cannot detect BA2. So this has become a very very difficult scenario without this genomic sequencing. This is a one part. Uh, in this Omicron wave or third wave, what you say here, I think this is the CME India has given this input by the surveying lots of physicians that fever has been a common feature, usually mild and goes away in next 2 to 3 days. But definitely there is a scratchy throat or sore throat, and it is the most important problem which persists for few days, and weakness and tiredness is quite common in such most of our cases. Headache could be there. Body ache is also very troublesome in some cases only, and backache, and I think not lots of tests have been done, but basically CRP they have been done. It was found almost slightly raised or within normal limits. And if it is Omicron, definitely the oxygen saturation is hardly affected and most asymptomatic by 4 to 6 days. But don't think that there is not long COVID here. Many times people are now saying that even after 2 weeks or 3 weeks, some the throat problem, some dry cough is persisting, and some exhaustion, a peculiar type of exhaustion is persisting. So I think we have already discussed here about the mild illness and this risk factors. This is very very important. I will say again that when you see a case of age more than 60, type diabetes, coronary artery disease, liver disease or CKD, a stroke, immunosuppression, then you should be very very careful to just hear sometimes the role of giving this is the drugs which we are already talking about, antivirals and others comes. So in CME India we gave a clear cut guideline that definitely multiple therapeutic agents are available for non-hospitalized patients with mild to moderate COVID-19. But who are those who are at risk of high risk of disease progression? The option one, whenever this Paxlovid will be available, this could be option one, but we don't have at present. So I think at this time, again when you think about this monoclonal antibodies, I think in this wave this has been overused, misused. So again, this is not a choice at present in most of your cases, but definitely I will say in the high risk of your patients, this remdesivir is back after the pine tree trial, which Dr. Nisith well told that 89% giving you protection for the hospitalization. So this is very very effective, and it is supposed to be effective for the Omicron. So again in the pine tree trial, when you go through this trial, even the OPD basis at the not on hospitalization patients, even at the OPD in the OPD basis, even at a center where the patient is going in a skilled center, just taking the remdesivir and returning back to home. But I am not at present advocating because our government of India doesn't allow for that at present. So it will be better only at the highly skilled center. Then definitely the role of this Molu already we have discussed. So this is how we are giving with the remdesivir. But with remdesivir, I will say that remember that no significant effect of this drug has been found in reducing hospitalization or death in people who had positive nucleocapsid antibody, that is 20% at baseline. So this is very very important point again. And there is no data of at present about its effectiveness in vaccinated people at present, right? We discussed already. And as far as the safety issues are concerned, a short-term use of 5 days is unlikely to have any long-term major concern on individual patient level. So this is very, very important here. So you have, then we also discussed about the moderate illness, severe illness, and then how to deal such cases where their patient is asymptomatic, no blood test are needed as much as such, only the physician discretion needed, then you do it, then isolation you do, then you monitor, this is very important. And if you get these features of moderate illness, I think this is crystal clear, then with red flag signs, respiratory rate more than 24, and oxygen saturation less than 94, you admit such cases. And then if there is mild symptoms but no comorbidities, then we can do this test according to the your case, your situation. So I think this guideline is quite clear here कि how to treat, how to give the symptomatic management. I think this is all available online, so you can see that. I think I will end here. So I think already we have discussed and we have. I think Dr. Nisit, can you just give your final comment on this?
No, I'd just like to add few points about radiology because there is so much confusion about whether to get a chest X-ray done or not, whether to get a HRCT done or not. So most people of COVID-19, especially Omicron infection, do not develop pneumonia, as we all know. Also, no single feature of COVID-19 pneumonia on a chest X-ray is specific or diagnostic, but a combination of radiological features like multifocal peripheral lung changes of consolidation, which are most commonly bilateral, may be present in COVID-associated pneumonia. Now, when a patient presents to a clinician in OPD with influenza-like illness, that is ILI, it's important to get a chest X-ray done because it's very important to rule out other conditions like bacterial pneumonia, pleural effusion, pulmonary tuberculosis, etc. Many a times we miss pulmonary tuberculosis because we think that it's just COVID-related infection. So it's important to get a chest X-ray done in OPD because all these things can mimic COVID-19, especially if the patient is presenting at day 10 or day 11 or 12. So in IPD patient, there is a definite role for chest radiology, serial chest radiology, to assess opacities and to rule out development of complications like pneumothorax, especially in those cases who are on BiPAP, and also secondary bacterial infection if the patient is deteriorating. Now, few words about HRCT thorax. It is a critical screening method. We have all seen its utility in wave 2, that is pneumonia happening because of Delta variant. So especially in cases of ILI with low saturation level, where suspicion of COVID-19 is high and RT-PCR is negative, it's better to get a HRCT thorax done to exclude COVID-19 pneumonia. So if it's CORAD 5, and even if it's RT-PCR negative, you have to treat it as a case of COVID pneumonia. Again, in critically ill patients with rising D-dimer levels, CTPA has an important role to exclude or confirm pulmonary embolism. And also, in post-COVID-19 cases, where the person is having persistent or new onset symptoms like hemoptysis, fever, there is definite role of HRCT thorax to rule out secondary infection like COVID-associated pulmonary aspergillosis, mucormycosis. One of our paper related to Kappa has been recently accepted for publication. So I'll be sharing it in the group in coming days. Thank you. Over to you all others.
Yeah, Dr. Raka, over to you.
Yeah, thank you. Thank you to all panelists and our team Clarinet. And there is no question in the chat box. And to our team panelists who have been joined with an acceptance from my link sharing. Can you have some questions? Dr. Abhishek, I am seeing you in the panelist. You want to ask something? Dr. Abhishek Srivastav? Okay. So I think we have done well, and it's time also around 8:57. So Ashish, can you give vote of thanks?
Yeah, I really thank first of all the team organizers, the Clarinet, for giving us this platform. Special thanks to Dr. NK for coming up.
Yeah, Abhishek is there. He has raised the hand. Abhishek, you want to add something?
Unmute yourself. Unmute yourself. Unable to unmute, he's writing unable to unmute, so he cannot say. But can you write? Can you chat? Can you give your question in the chat box?
Arpita can unmute her. Unmute him. Arpita, can you unmute Dr. Abhishek Srivastava?
I can send the request. He needs to unmute himself. I'm sending the request, sir.
Okay. Okay, Ashish, you carry on.
Yeah, Dr. Ashish.
It was a wonderful talk, especially about what things were going on in the minds of the clinicians regarding the vaccination, the booster. Thanks to Dr. S.K., Dr. Shashank for their insights. Real thanks to Dr. Nishit for the treatment and Dr. Clarence for coming up with what we have coming waves, like he has identified how new waves are coming and have come. And special thanks to Dr. M.K. Singh for giving us this opportunity to join together. It has been a wonderful experience with me and Dr. Akar together. We thank you all for joining this Global Diabetes Forum and CME India with Clarinet for coming together for this scientific piece. And we do hope that we'll be joining again soon. So thank you, and everybody have a safe time.
I want to add some spice in that.
Yeah.
Thanks, Dr. Clarence, for clarity. Dr. N.K. Singh and Dr. Nishit. Dr. Nishit for making some Nishit things in this CAB. And thanks Dr. Shashank Joshi and Dr. S.K. Gupta for super power in this COVID. So very big thanks to Clarinet again for that clarity in the net. So again we all are thankful. From Global Diabetes Forum, Dr. Ashish and Dr. Raka pays a big salute to you people for bearing us in this Sunday, because your family is speaking. I know that it's a great strength you people have shown. COVID is not at all gone. We in nutshell can say that vaccine is the real choice. So being physician, there should be one opinion from this forum to all of us, that we should not say in a layman word that it's gone. Vaccine has to be promoted, and we be with the vaccine. Thank you all. Thanks.
Thank you all.